Good afternoon, everyone. Thanks for joining us. We'll give it a couple minutes to fill up the room here. Good afternoon, everyone. We're going to see the room filling up here. We'll give it another minute or so. Good afternoon again, everyone. We'll give about another 30 seconds to fill the room up here.
You know, I just tried to do the ISTH thing and it didn't work. I was on hold for a half hour. I haven't even recorded my thing. Totally pissed off.
I'm glad you're here to join us, though, Mike. We're live now, so. All right. Good afternoon, everyone. Thanks again for joining us once again for our weekly Wednesday webinar series. Today's webinar is on the State of the Science Research Summit. My name is Brett Spitale, and I'm the Vice President of Advancement here at the National Hemophilia Foundation. At any point during the webinar, if you'd like to ask a question, please use the Q&A feature at the bottom of your screen. We have NHF staff members monitoring these questions, which we will pose to our presenters after the presentation. Please note this webinar is being recorded. It will be available to the public on June 25th on the NHF website under the Events tab. I'm joined today by Len Valentino, President and CEO here at the National Hemophilia Foundation, and Mike Recht, the Chief Science Officer at the American Thrombosis and Hemostasis Network. Thank you both for taking the time to join us today. Len and Mike, I'll now turn it over to you to get us started. Oh, Len, I think you're muted. I'm sorry.
Good morning, good afternoon, and good evening to everybody participating. Thank you for joining us, and thank you, Brett, for the introduction. So we're going to talk today about the state of the science, which we're focusing this presentation on. A world without bleeding disorders starts with research. Next slide. And as I said, the vision for the National Hemophilia Foundation is a world without inheritable blood disorders. But we believe that this starts with research, as I said previously. Next slide. We're aiming for lasting impact. And one of the ways that we can do that is by looking at what's been done in the past and agree that we've made significant progress in treating inherited blood disorders. But we need to accelerate these efforts to make meaningful differences for today, but more importantly for the future. So that's what the creation of this program is hoping to do, is to advance the care and treatment for people with inherited bleeding disorders. Next slide. Our goal is to develop a blueprint to achieve the vision for the future. And NHF is leading this community-driven journey along with our partner, the American Thrombosis and Hemostasis Network, to shape the future of research for bleeding disorders. What's our goal, you might ask? Well, the goal is to establish a clear understanding of what the most pressing issues are that challenge our community. What are the gaps in care that people who live with these disorders are facing? And then through coordinated effort, including deliberation and discussion, to decide on the areas of greatest opportunity to continue to improve the lives of people who live with these bleeding disorders. Next slide. So how has this process been done? Well, the first thing was really bringing people together to align on a focus. And we brought together leaders in our community from all aspects, including people who live with these disorders, so-called subject matter experts who have the lived experience of these disorders. Who could be more expert on their disease than they are? We also brought together healthcare professionals, clinicians, researchers, industry partners, and our federal partners as well. Once we were able to align on a focus, we needed to define our priorities. We did this through listening to the community, listening to all of those individuals who were willing to share their voice. And we collected information through a number of different channels: direct communication, sitting down in focus groups and meetings, community surveys, as well as other opportunities to really interview in depth people to understand where the priorities should be. Our goal was to identify 4 to 6 research priority areas and then develop a framework around that the community could advance, with the goal of fostering progress through collaboration, establishing a functional platform that encourages partnerships and collaboration even beyond the inherited bleeding disorders community. Next slide. So what did we do? As I said, we started out with focus groups. We needed to understand what was possible, what was the vision that people were hoping for into the future. We asked our participants not to be constrained by time, effort, or money, but just to think about what the possibilities might be, to think about the blue sky. If we could have whatever we wanted, what would that be? That was critically important to understand that direction. We then sought to hone that blue sky vision through additional community input. What matters most to the future of care in the inherited bleeding disorders community? And we hope to do that by having an open comment period where we collected more than 250 responses from the community to help hone that vision of the future. We also conducted listening sessions with various community members, researchers, other healthcare professionals, but most importantly, with subject matter experts, the people who live with these disorders on a day-to-day basis, and family members who care for those loved ones with these disorders. So it was critically important to get the voice of the patient, the voice of the family included into this so that we understood where the issues were. We also worked with an organization that does listening, professional listening, to do in-depth focus groups to really understand where the gaps might be. And these focus groups were conducted with subject matter experts and family members, with chapter leaders, as well as industry partners and healthcare professionals. We also conducted a survey of the community, both in the subject matter experts, i.e. patients and family members, but also with healthcare professionals. We were able to take multiple different inputs and distill that down so that we could understand what the gaps were, what people in our community were facing on a regular basis. Next slide. So by listening to everybody across the community, and as I said, it included patients and caregivers, patient organizations and local chapter leaders, healthcare providers, as well as industry providers. And you can see there the number of groups and participants that we had in each of these listening sessions. The primary topics that emerged are shown on the right, but many of those are ones that you would anticipate from your own experiences. The experiences of living with a bleeding disorder, the most bothersome symptoms and unmet medical needs, the healthcare professional relationship and treatment experiences and information sources. And of course, we wanted to explore individuals' experience with research, what their perceptions of registries and observational research, as well as clinical research might have been. Our goal was to identify priority areas of research and any barriers to completing this research, ways to improve the relationships between healthcare professionals and our subject matter experts, and then addressing barriers to clinical trial participation. So we had many primary goals that were being addressed in these listening sessions. Next slide. So we also did this cross-community survey. The survey was distributed with the help and assistance of our NHF chapters and FDA members to individual families. We separately disseminated a survey to the HTC network of providers with a goal of comprehensively including community voices in shaping research priorities by collecting input on emerging themes. Next slide. So we had 6 areas of focus that emerged. At this point, I'm going to turn it over to Dr. Recht to talk more about this.
Thanks, Len. I really appreciate it for this opportunity. And for those of you who don't know me, my name is Michael Recht. I'm a pediatric hematologist, been taking care of kids and adolescents, young adults with bleeding disorders for about 25 years. I was lucky enough to be invited by Dr. Valentino to be co-chair of the State of the Science meeting. And so I've been working with him and Michelle Wickop and Maria Santayella and other members of NHF to really put together what's going to be a very exciting experience later this summer. So after all that groundwork that was done by NHF, we took a real qualitative research approach to the input we got from all the focus group, all the listening, and came up with these 6 different working groups that are going to focus on potential recommendations for research moving forward. And I'll go through each one of these individually, but what you can see, there really are themes that came out that are applicable to all inherited bleeding disorders. There are themes that led to working groups that were disorder-specific priorities. And then we have 2 working groups that really are looking at the infrastructure and capacity opportunities in research of inherited bleeding disorders. So could you move to the next slide, please? So the first working group is going to focus on hemophilia A and B. And what we heard from the listening groups was that people were really interested in new therapeutics, delivering drugs in a different, more effective and convenient way, trying to figure out what the best goals for gene therapy might be, looking at the evolution of patient-informed care. We heard a lot about sex and gender biology. We heard a lot about pain and other comorbidities, looking at how we can enhance our ability to collect data across the lifespan, looking at aging in the hemophilia population, and looking at really what it means to have non-severe hemophilia. And the key question that we asked our hemophilia working group to concentrate on is, how can we use new technologies to discover therapies that make life with hemophilia easier while working to deliver a safe and meaningful cure? Next slide. The second working group is looking at von Willebrand's disease, platelet dysfunction, and other inherited bleeding disorders that affect mucocutaneous tissue, or anything that's sort of pink and wet, so mouth and nose and uterus. What we heard when people were talking about what they would want to focus on in terms of research were how to obtain targeted and accessible testing and therapies for this group of disorders, for all of these disorders, no matter if you're on the more severe side or the more mild side, determining whether gene therapy might ever be a possibility in these disorders. Again, looking at how we can collect data across the lifespan, again, looking at aging in this population, and looking at outcomes research and patient-reported outcomes, with the key question being, what is needed to introduce a more targeted and accessible diagnostics and therapies for all people with all of the disorders that are encompassed by this working group. Next slide. Then we created a working group focusing on those ultra rare disorders. And again, you're going to see some consistencies between these working groups, because like the people who had thoughts about what we should be researching in hemophilia and von Willebrand's disease and platelet disorders, the people who gave us input about doing research in these ultra rare inherited bleeding disorders, again, talked about research that should be generalizable to all the disorders and all the phenotypes, meaning whether you have mild symptoms, moderate symptoms, or more severe symptoms, seeing if gene therapy would ever be a potential for these kind of therapies, really dig into basic biology of some of these rare deficiencies. And again, look at the aging population, looking at enhancing our ability to collect data across the lifespan and looking at patient-reported outcomes, with the key questions being, how can we better understand the biology of these rare diseases? And how can we stimulate research and optimize the regulatory process to improve diagnostic and targeted treatment? Okay, let's move on to working group 4. So in those first 3 working groups, there is so much information that would be pertinent to women and girls with these disorders. But we didn't want to dilute out the expertise in sex and gender biology and sex and gender research. So what we decided to do was create this 4th working group that paid attention to the research priorities for the health of women and girls and people who have the potential to menstruate. And what we heard people wanted us to pay attention to were novel therapies for reproductive tract bleeding, what the risks are for gene therapy in women and girls who have inherited bleeding disorders, what can we do to improve non-invasive prenatal diagnosis, how sex and gender biology across these inherited bleeding disorders might affect the clinical expression in a particular individual, and then getting to the basics. What are we going to do to prevent not only joint bleed, hemarthrosis means joint bleeds, but how can we affect the damage that bleeding into joints can cause in women and girls with blood disorders? And again, really basic, just how can we get women and girls included in some of the clinical trials that are done, usually mainly in men with hemophilia. The key question we pose to this group is, how can we improve care for women and girls with bleeding disorders through a better understanding of sex and gender biology of bleeding, as well as through the use of new tools like non-invasive prenatal testing? Next slide. So then we get to the infrastructure working groups. And the first of those 2 working groups is the working group we asked to pay attention to diversity, equity, and inclusion in health services research and implementation science. So what we're really asking this group is to look at how we can ensure that all people affected with any inherited bleeding disorders have access to care, how they have access to research, how we can take what we learn from our public health approach to inherited bleeding disorders and bring that down to the individual to improve their ultimate outcome. The key question we are asking this group, which, this group has so much information to cover that we really had to ask them to focus. And what we asked them to focus is how we can make the greatest impact on equal access to care and research and be more inclusive of our coverage. And is there the potential that digital tools could be implemented to reach this goal? And finally, the 6th working group is really looking at how we can keep the momentum moving forward in research in inherited bleeding disorders. As like I said at the beginning, I've been in the care of people with inherited bleeding disorders for almost 25 years. The last 5 years has probably been the most exciting time professionally for me because of all the advances that are occurring in this field. But we have to figure out how we're going to optimize the research infrastructure so we can continue that momentum moving forward, and where the funding is going to come from, who's going to develop the future research protocols, and how are we going to convince people to come into this field? I think one of the big issues that many subject matter experts and their families might face is finding a provider of care that understands an individual's inherited bleeding disorders and is willing to participate with us to move the field forward, to create new knowledge so we can continually improve the care that we're able to give. the key questions that we put to this working group is how can we build and fund a research network that is centered on patients and patient care and is designed to reduce the burden of participation in clinical trials? And how can we encourage more trainees to join our professional community so that people with bleeding disorders are assured of having care into the future? Next slide. So what happens next? So we formed a steering committee. Len and I chair that committee. We have members throughout the United States of experts in basic research, translational research, clinical research, clinical care as part of that steering committee to help guide the strategic focus of what we're trying to do. I just talked about the multidisciplinary working groups that we are asking to come up with actionable priorities in research that come from the information that we got from the listening exercises. We will be having the State of the Science Summit in September with the idea that this summit, which is going to be done virtually, will convene the entire community to hear speakers and, most importantly, to participate in an active dialogue. Out of all of that, we are going to come up with a research blueprint going into the future. And this is going to be derived from what we learn from our summit. Next slide. So this is what the summit looks like. It's going to be on September 12th through September 15th. It is going to be full day sessions on the first 3 days and a half day session on the fourth day. In the morning session, you're going to hear every morning is going to be started out with a welcome. You're going to hear a short snippet from someone who is affected by the condition of which we will be speaking about during that session. We then have invited internationally recognized experts, both inside our field and external to our field, who might have something that will help us develop our research plan moving forward. We'll then have the working group chairs give a 30-minute summary, have a little bit of a break, and then we have a good solid hour and a half where everybody who's attending the summit is going to be able to participate in the discussion. So we don't want this discussion to devolve into just the researchers talking to each other, because we have so many ways to talk to each other currently. But we want the researchers, the providers, and the subject matter experts and their support groups to be intimately involved in these 90-minute discussions that we have after each session. So you see on the first day, we're going to have working group 1 and 3 present. On the second day, we're going to have working group 2 and 4 present. And then on the third day, working group 5 and 6 will be presenting. And then on the fourth day, our fearless leader, Len Valentino, is going to be summing up the entire process. And Len and I and members of our steering committee will be participating in an open dialogue where everybody is invited to reflect on what's happened in the past 3 days and to help guide us as we move forward to create this blueprint. So next slide. So save the dates, September 12th through the 15th of 2021. It will be virtual, so no travel will be required. I am really looking forward to it. We've been really working diligently to come up with an agenda that should be interesting for all stakeholders in this community. So save those dates. We really look forward for all participation. And I think that might be the last slide. Yep. So time for discussion. Anything that people want to talk about?
So Mike, maybe I could ask you a question first. Is this State of the Science Summit available to people, anybody in the United States or only in the United States? Can people outside the US, for example, in Europe, participate?
It's a virtual summit. So although our working groups and our plenary speakers are mainly US centric, it will be available for anybody who wants to participate.
Thank you.
So
Yeah, I would actually encourage participation from outside the US as well, because the problems that we're going to be talking about and addressing are not limited to borders. And I think many of the challenges that are faced in the United States will be similar challenges faced outside of the United States as well.
So, Mike and Len, we do have several questions that have come in, and I'm going to just start at the top and start going down the list here. Feel free to jump in at any point. First question comes in: how are the subject matter experts, or SMEs, chosen, and was diversity ensured?
So definitely there was an effort towards having diversity in terms of diagnosis, diversity in gender, race, ethnicity, sexual orientation, as people from various communities, rural versus urban. So we really strove to have as much diversity as possible in each of the working groups. Of course, we strove for that, and we worked with members of each of the working groups to ensure that we had that representation. We also have representation from, for example, healthcare providers. We have a requirement to have a physical therapist, a social worker, a physician, and a nurse on every working group, so that we have that diverse perspective coming in as well. We also have an NHF board member on every working group, to bring that perspective in. And we try to select people who were board members who were impacted by inheritable bleeding disorders, whether directly or through a loved one.
Right. I don't have a whole lot to add to that, other than to say that we on the executive committee and then the steering committee level worked very hard to ensure as a diverse input from our subject matter experts as possible. Like I said, I've been involved in clinical research in hemophilia for a quarter of a century. And this is the first time that I would say that the patient voice is front and center. I have done so many clinical trials, so many research studies that have originated from my own mind. And the thing that is consistent across all that is I'm answering questions that I thought were important. And I still think they're important. But what I've never done until I got involved in this effort is ask the people who are affected by these conditions, what's important to you, and how can we design research questions that will get to those answers?
Thank you both. The next question that comes in is, what was the process of prioritizing the topics, or the working group topics?
So based off the data that was acquired through all the different listening sessions that Dr. Valentino described at the beginning of the talk, we took a real qualitative research approach and listened to what everybody said, pulled out the exemplars or the commonalities between what people talked about, and then created these working groups based on that. Len, you were much more involved in that. I don't know if you have anything.
Yeah, no, I think it was a long process of trying to summarize. When we did the sort of the ethnographic research, when we had really in-depth conversations, we had an outside vendor who really helped us understand and categorize that research to put it into specific areas. But it was pretty clear that the 6 areas of focus were ones that emerged that were sort of the large buckets, but the specific areas within them, many of those areas of focus came from people who live with these disorders and their loved ones. So it was clear there's others that were definitely provided by healthcare professionals, but I think it's a really good mix and a good harmonization of the gaps that are perceived broadly within the community.
Yeah, I would agree with that. And, I ran through those priorities that we charge the working groups with pretty quickly, but I think you can see the commonalities between the different working groups, and those commonalities really came from our subject matter experts and their families.
Yeah, that's great. A great question here for both of you. Thus far, what have been the most challenging aspects of the entire process?
So I would say that early on, it was activation. It was getting people activated. I think it was perceived as somewhat of a daunting task. And there was a little bit of trepidation going into this. But I have to say that once we overcame that initial inertia, the momentum has been unbelievable. I've sat in on a number of the conversations and meetings of the working groups, and I know Dr. Recht has as well. And I have to say that the discussion is broad and very engaging, with equal partnership in the conversation between the healthcare professionals, the subject matter experts, as well as our industry partners, and more importantly, representatives from each of the federal agencies, the FDA, HRSA, NHLBI, as well as the CDC. And I think it's really been critical to have that type of involvement in these working groups. We thought early on that we needed to elevate the voice of the patient. And Maria Santaya has really done a lot of work in terms of working with our people who live with these disorders to make them feel more comfortable and more empowered to participate and to communicate their needs and what their opinions are. And that's why we decided to really, elevate their status, considering them the subject matter experts on their own disease, and really empowering them to have a strong voice in the direction that these working groups are taking.
Yeah, we're asking the working group chairs and the working group members a lot. This is a big task that we've placed in front of them. And my concern going in was that we might have trouble finding chairs or finding working group members. And what I was so pleasantly so pleased about was every single person we asked said yes. And every single person that we asked said, how can we help? I think the biggest challenge we saw was after we formed the working groups, that what we were asking them to do seemed daunting at first. And like Len said, each one of the working groups had a little bit of a slow start, but now things are rocking and rolling. And I come out of any one of those working group meetings that I attend just so impressed at the breadth of experience that's available, that the inclusiveness of opinions that are being listened to, and really just the deep thought that's being put into the questions that we're asking them.
And I would emphasize that where we're at today is certainly not a finished product. And where we will be on September 15th is not a finished product. And there's really tremendous opportunity for community input, whether that's from additional subject matter experts or family members or others that touch the inherited bleeding disorders community, either as a healthcare professional or other, to participate in the State of the Science Summit. That's really what we're asking, is to get broad participation so that your voice can be heard. One of the projects that we're working on are called remote participation groups. And these remote participation groups are opportunities for an HTC or a chapter to host a number of their constituents, their clients, their subject matter experts during the State of the Science, to have focused conversations about issues. So for example, if there was a group that wanted to convene 10 or 12 people with von Willebrand disease, to come together during the von Willebrand disease session to have discussion and potentially provide comment into the state of the science. We welcome that. Again, we're going to be setting some of these remote participation groups up with the intention of ensuring that we have broad representation and diversity in various aspects of our community. But this by no means means that these remote participation groups can't be supplemented when there's individual interest in a local community, whether that's from an HTC or a chapter. We welcome that input.
Yeah, I think one of the really important aspects of what we just talked about is the importance of the word blueprint in this. And just like when you have a blueprint when you're building a building or a house, that's not the final product. That's just the beginning. So, Len and I were talking about this yesterday, that how we're going to use this document to keep ourselves and to keep everybody involved accountable. And that we're not going to write this and then it's going to go away. That, if this is something that we're going to be able to go back on and say, okay, we said this is a priority. Did we prioritize it? And then the other thing about a blueprint, remember, is you build your house and, if it's not exactly perfect, you do some remodeling. So that's the idea of this, that we will come up with these recommendations, hold ourselves accountable for the outcomes of those recommendations, and be continually reassessing the appropriateness of what we suggested and be able to change what's not working.
Thank you both. Another question that comes in, this is more of a point of clarification, I think, if you can help out for maybe our consumer audience, really. What's the difference between basic research, translational research, and clinical research?
When that came out of my mouth, I was like, oh, I got to take a step back and say what that means. So basic research is the research that you think about when you're working in a lab and working with cells or working with RNA and DNA. Translational research is the research that occurs when you make a discovery in the lab and you move that into either animal models or into human beings. And then clinical research is when you're actually asking questions using people with inherited bleeding disorders as the participants in a trial. I thought that while I was saying it. So I wish I had said something during the talk.
No, that's great. That's great. Here's another great question. What has inspired this entire process?
Well, I think the inspiration for this process has really been to improve the lives of people who live with inheritable bleeding disorders. I look back on the more than 35 years that I've practiced medicine, taking care of people with hemophilia, von Willebrand disease, and other bleeding disorders. And I asked the question, can I do better? Could I have done better than I've done in the past? And I think, we all probably can ask that same question. Could we do better? And for me, the clear answer is absolutely, we could do better. We could give people who live with these disorders a better quality of life. And for me, that what we're striving for is health equity. It's equity and outcomes for people who are diagnosed with these disorders, and have their outcome, their life expectancy, their quality of life be similar to somebody who's not impacted by one of these disorders. So really, it's all about achieving health equity in our community. And I think we're a long way off from being able to achieve that. So the simple answer is, can we do better? Absolutely. And I think that the way that you move towards doing better is by addressing specific gaps in care that people who live with these disorders identify, and then doing the research to close those gaps. So for me, the process is pretty simple. I don't know, Mike, if you have some other thoughts on that.
Yeah, I'll bring it down to a personal level. And many people who I've worked closely with have heard this, me say this before, but I started taking care of people with inherited bleeding disorders in 1992 in New Haven, Connecticut. And so that was at the tail end of the HIV era. And, you know, New Haven's sort of a small town. The treatment center there is excellent, but, you know, it's a medium-sized treatment center. I had the luck of working with Diana Beardsley as my hematology mentor, and we had a lifespan treatment center at Yale. That first year I was involved in hemophilia care, I was involved in the care of 50 people who died from HIV. And if you had asked me in 1992 that we would have safe factor, non-factor molecules, gene therapy trials that essentially can eliminate bleeding when reviewed sort of at the population level, would that be good enough? I would be like, oh my God, that is amazing. But now we're here, and that's not good enough. I think that we have done our best to move this field forward, but that doesn't mean we can't be better. And to, you know, reflect on what Len said, how can we be better? You know, we're going to figure that out going through this process. There are still some bleeding disorders that we treat today like we treated hemophilia back in 1950. And that's not okay. We need to really make sure that every single person affected by an inherited bleeding disorder gets safe, effective, convenient therapy with the goal of curing everybody.
Thank you both for sharing that. We appreciate that. I'm going to go to the Q&A here now, and I'm going to start with you, Len, on this one. If the participants are selected or chosen by NHF, how can we assure the community that the message heard are not just those reinforcing what NHF is already working on?
They weren't chosen by NHF. They were chosen by the steering committee and the working group chairs. So NHF convened, but did not select anybody to participate in this except one person, Dr. Recht.
Great. A good choice. Moving on here, let's say, will there be other outcomes or action items out of this outside of research?
Yeah, I think the simple answer to that is yes. So when we first provided orientation to the working group chairs, we talked about these 6 areas of focus and the research priorities, but we also created sort of a parking lot for issues that were related to educational gaps, both for providers and people who live with these disorders. Educational gaps and knowledge gaps in the payer public policy arena as well. Parking lots for advocacy efforts in addition to education. So I think that what we're hearing is not always a research addressable question or gap, but when those are identified, we put those into the parking lot. And the advantage of doing that is that in every working group, there's at least 1 or sometimes 2 or 3 NHF staff members who are also part of those working groups, who are listening and taking in all of this information with the intent on passing that along when there are these types of parking lot issues that need to be translated into educational materials or programs or public policy issues or payer issues. It's a really important question.
Yeah, when Michelle Wickup and I were working with chapter directors in creating the survey, what the biggest obstacle we had was helping the chapter directors understand the difference between research and programs. Because, whatever chapter directors are on the call right now, you guys like getting stuff done, and you see a problem and you want to create a program to fix that problem. And we kept trying to reframe, how can we turn this into a research question? And the real issue is, like Len said, there are so many issues that are being raised within these working groups that aren't exactly questions that can be answered by research, that will all be collected when this final process is over.
All right, going down the list here. Next question comes in. What do you mean by a blueprint? What is this going to look like, and how will it impact me as a patient?
So I think a blueprint, much like you think about a blueprint for constructing a house or constructing, a building, are the directions that somebody else needs to utilize to actually build that. So what we anticipate happening is that there will be a series of manuscripts published, one from each of the working groups that highlight their discussions and deliberations, and then provide a series of recommendations as to what the priority questions are, and potentially what the ways that those questions could be addressed. And those manuscripts will be published, as I said, one from each of the working groups that will highlight, that specific focus area. And then what we intend on doing is distributing those widely, having additional opportunities for discussion and debate and deliberation around those papers to ensure that the community is aligned with that. And if they're not aligned with it, then we have to understand where the process might have gone awry and course correct. But the goal then is to utilize this blueprint for future research. So for example, if there is the identification that in a particular study, for example, in a pediatric gene therapy study, that we need to have a certain type of outcome included in that trial, that would be the mandate for such trial to include that outcome. And if there's a specific question that could be addressed by laboratory research, as Mike was talking about, then there's the basis for somebody to create their research project focused on that specific question to be able to provide an answer and advance the community forward. So we see this blueprint as really a means to now constructing additional research in the future. It's not going to have all the answers, but it's going to have directions to be able to conduct research and advance the field forward.
Yeah, and one of the, just a corollary to what Len said, we are planning on having these, peer-reviewed scientific papers published that will summarize. But one of the important things that we're also going to be doing using the power of NHF is to disseminate this to the entire community. So, we are going to use this blueprint to keep ourselves accountable, but we also are going to communicate it in such a way so everybody in the community knows exactly what we're thinking, exactly what our goals are, and we can be held accountable from the community as well.
Great. Thank you both. The next question that comes in is for consumers who have not been able to be included in the process yet, will there be an opportunity to add opinions?
Absolutely. That's what the virtual summit, September 12 to 15, is all about. It's getting community input. And as Mike went through the sort of the overview of the schedule, there's opportunity for input and discussion from the community members. And what we would really like to be able to do is there'll be a number of opportunities. The website, which Brett can provide that in the chat, has gone live now. And there'll be materials that'll be posted there, videos, short presentations to prepare them for what they're likely to hear during the virtual summit. So we really want to provide some additional materials and resources to people so that they're prepared and ready to participate. And I think in addition, the website will have an opportunity to provide feedback and questions into the state of the science as well. So we really want to make sure that this is community participation is a priority.
Yeah, we selected moderators for each one of those 90-minute discussion sessions after the presentations, who we know are excellent in bringing in everybody who's participating and won't pay attention just to the scientific questions or the questions from the researchers, but will really forceful in bringing that patient voice forward during the discussion sessions.
Yeah, one thing that I'll mention in addition is that it was critical to have the patient voice included in our steering committee. And we do have representation from a woman who has an ultra rare congenital platelet disorder that results in severe bleeding. And having her voice on the steering committee has been important in terms of ensuring that the patient voice, the patient is continued to be represented in all of the deliberations at the highest level of this process, but also then by working with each of the subject matter experts in the working groups to ensure that they're continuing to provide input into the process.
Great. Great. Thank you both. I did provide that information in the chat. You can also just go into the research tab at hemophilia.org if you're unable to see that or don't get to that.
And Brett, is the registration is currently open, correct? So people can now register?
They can. Yes, sir. It opened a couple of days ago.
Yeah.
Next question comes in: as an individual with a bleeding disorder, will this information be over my head? Will I be able to understand it?
We sure hope not. The
Yeah.
whole idea is that we're going to be presenting the methods by which the various working groups came to what they considered their priorities in research. Our plenary speakers, they're from all over the map, some within our bleeding disorders community, some from outside of our bleeding disorders community, but we have told them very specifically that the general population is going to be attending, and we expect a lot of people who aren't scientists to be participating in this. So we asked specifically to please create a talk that is understandable.
And I think this is also where the value of these remote participation groups could come into play. For example, having these facilitated discussions at a chapter or an HTC where you could bring in, professionals, healthcare professionals to help distill down or understand, interpret some of the conversations would really be helpful as well to ensure that we have the entire community at a level to understand everything that's happening.
Yeah, for one example, for our plenary speakers, I had this goes way back into the early 1980s. I have a medical ethics professor from the University of Wisconsin who I took his course in 1983, maybe 82. And, he had such a profound impact on me. He's a pediatrician at University of Wisconsin, medical ethicist. And we asked him to talk about the ethics of gene therapy. And, that will be a talk that will be specifically directed to non-researchers.
That's great. One point of clarification that came in through the Q&A: if someone on the call is interested to join a remote participation group for the summit, how can they do that? And I'd encourage you to go to the website that's in the chat there. There's either contact information for Maria Santaya that can help you out with that. So please, I encourage you to go to the website and check it out. You can find all that information there. This is looks like one of the last questions that came in. It's a longer one. I'll pose this to you both here. You were speaking about accountability. Who is actually accountable for the implementation of the blueprint, and who will lead and complete the research? And what support will the researchers receive?
You will. This is the community. This is not NHF. This is the community. I cannot stress that enough. You are all accountable for this. This is supposed to be your voice, what you're asking to be done. So, for example, if there is a researcher in an academic institution who takes up one of these questions, they're the one that's accountable for it. And I think we should all hold those people accountable for doing this research. We should encourage our industry partners to take on these questions, our academics to take on these questions as well. And for that matter, our community, our subject matter experts to be reinforcing that. I can't emphasize enough, this is not an NHF initiative. This is a community effort to really drive the value and care of people forward.
And one expansion on that, Len, is to bring our government partners along with us.
Right.
So have the National Institutes of Health understand what is important to this community so we can help them develop the resources to fund the kind of research we want to perform. Have the FDA hear what we are concerned about as they think about approving new therapies for inherited bleeding disorders. Have the CDC be part of the process in surveilling for complications of inherited bleeding disorders.
Great. Well, Len and Mike, I'd like to thank you both for taking the time to join us this afternoon. I appreciate you guys coming in and really sharing this very, very important information with everyone. I'd also like to take the time to thank each and every one of you for joining us. Please note that this recorded webinar will be available on Friday, June 25th at hemophilia.org under the events tab of our archive with all of our other archive webinars. Also available there under the events tab is our upcoming schedule of weekly Wednesday webinars. Again, Mike, Len, thank you both for joining us. We appreciate it, and everyone have a wonderful afternoon.
Thank you.